Good morning, everyone. Welcome to the UCT virtual ESG meeting. My name is Dr. Suraj Gaire. I'm one of the registrars working at UCT currently. I think I'm going to begin my presentation because we are in time already. I'll be presenting on tuberculosis of the temporal bone. Just some disclaimers. Consent was obtained for the use of the patient data. No, there's no intent on copyright infringement, and all my relevant data is referenced. So we're going to start with a case. So I have a case of a 40-year-old gentleman who was RVD positive. He defaulted his ARVs about 3 months before he presented to the hospital. He was referred from a primary healthcare institute to the Department of Medicine with a query of meningitis. He had presented there with a gradual history of headaches, which were worsening, and the front headaches worse on his left-hand side and on his right-hand side, with associated neck stiffness, fever, and intermittent double vision, as well as photophobia. He also revealed a long-standing history of hearing loss in both of his ears, which was worse in his left ear, and with a long-standing history of left-sided autouria, which had currently resolved in the last month. He also felt a headache. In terms of his headache, he felt that it was mostly over his left frontal bone. He felt it deep in his head. It was constantly, intermittently worsening, and with pain felt behind his eye, with no associated nausea and vomiting. His general examination, he was apyrexial with normal vitals. His CNS examination revealed a GCS. He had mild neck stiffness. His left cranial nerve 6 had a palsy, but his trigeminal nerve was intact, and all his other cranial was intact, and there was no other focal neurological signs. His ear examination, on the left, he had no mastoid tenderness. His external auditory canal was dry. His tympanic membrane was intact. It appeared dull and erythematous, but there was no perforation, no squamous debris that was seen. The right ear examination was normal, and his nose examination revealed a left frontal sinus tenderness, as well as bilateral nasal polyps with rhinorrhea, with a Molson score 2, and pus in the inferior meatus of both of his nasal fossa. Relevant investigations that were then done initially, the bloods were done, which showed a white count which wasn't raised, normal hemoglobin, normal platelets, and his electrolytes were normal as well. However, he had a syphilis test done, which was reactive, as well as an RPR, which proved that it was a current infection. He had a lung puncture done at that point, which was clear and colorless. It showed a glucose of 2.5, protein of 0.66, 0 polymorphs, and lymphocytes of 82 with a CLAT negative and a TB PCR negative. He was admitted for IV antibiotics and treated for meningitis, as well as for syphilis by the internal medicine doctors. And then he was then sent for an audiogram, which showed a left ear moderate to profound mixed hearing loss, and a right ear with moderate to severe mixed hearing loss. A CT scan was then conducted, which showed right and left pansinusitis, as well as, with no orbital intracranial complications. Pacification of his left middle ear, mastoid ear cells, and petrous apex, as well as bony destruction. This is the CT scan that I just mentioned now, and as you can see on the CT scan itself, there's a pacification. It's just 2 images on the CT scan, and we'll put the video up, and you can just see that there is a pacification of the mastoid ear cells, as well as the middle ear, and there is a destruction of the temporal bone that is witnessed, as well as the petrous apex. This was his audiogram, which I just described earlier, which showed an asymmetrical hearing loss, which is also his left-hand side, which is the side he complained about. So his initial management, he was admitted for IV antibiotics. He was treated for meningitis as well as syphilis. He had analgesia given to him. He had intranasal corticosteroids, intranasal decongestant. Day one post admission, we decided to take him to theatre to clear out his sinuses. And so he had a functional endoscopic sinus surgery, which showed a chronic with nasal polyps. And he had a left ear myotomy grommet insertion, and of note in the ear, and there was pus that drained from the ear at that point. Yeah. And he had so that pus was sent for culture and showed 3+ gram positives, 3+ gram positive bacilli. Continuing his management. Post-operatively, his headaches improved, but still present and intimately worsened. His examination, he remained apyrexial with normal vitals. However, his central nervous system examination remained normal, but he still had a residual left abducens nerve palsy, which was slightly improving post-op. And his trigeminal nerve remained intact with neck stiffness improving. His left ear, the grommet remained in situ, was not frankly draining a few days later. And the decision was made to do a cortical mastectomy later. And this was because we wanted to get some sampling and to assess the patient for what was the actual cause. So he had a cortical mastectomy done. The findings were sclerotic mastoid with extensive granulation tissue, which was suggestive of TB. And there was no pus. The specimen was sent for TB MCLS, histology, routine MCLS, and he also had an abdominal ultrasound, which was requested by the physicians, which had actually shown intra-abdominal, which was actually suggestive of intra-abdominal TB. A final aspiration was also conducted of a left-sided neck node, which seemed fluctuant, and that had drained straw-colored perineal discharge at that point. And he was empirically started on TB treatment based on the findings intraoperatively of the granulation tissue. So because of the granulation tissue and because of the TB, the abdominal ultrasound of TB, as well as the FNA from the lymph node, which later revealed granulomatous inflammation, we started him on TB treatment, and he slightly improved initially and then improved gradually over time. So we treated him for TB and he was improving at that point. So my presentation today, I'll be talking about TB of the temporal bone. So tuberculosis is an important and relevant communicable disease, as it remains a major cause of morbidity and mortality globally. Tuberculosis is classified into either pulmonary or extrapulmonary and can theoretically affect all parts of the body. Tuberculosis is a chronic granulomatous infection caused by Mycobacterium tuberculosis, and tuberculosis is predominantly pulmonary. However, 12–15% of cases have been reported of extrapulmonary spread involving sites around the body. On rare occasions, the temporal bone may be involved with TB otitis media as well as TB mastoiditis, which have been reported. The incidence of TB otitis media is said to be less than 1% of TB cases, and that of TB mastoiditis being even less. So the WHO estimates that 8 million cases of tuberculosis are reported annually. The majority of cases occur in Asia and in Africa, with 55% happening in Asia and 31% happening in Africa, but this could just be an underestimate of the African cases. TB in the temporal bone is extremely uncommon, reported as less than 1% of all cases of chronic otitis media. The incidence is in developed countries more rare, with 0.04% being reported in cases of chronic otitis media. The BCG vaccination and the use of effective anti-tuberculosis therapy has caused a significant reduction in the incidence of TB in the current stages. In the developing world, TB remains an important differential diagnosis for chronic otitis media, especially which is not responsive to conventional therapy. A study from Africa of more than 11,000 patients with TB identified over 6 years had 43 patients which were diagnosed as having tuberculosis otitis media, which is 0.37%. In terms of pathogenesis, there are 3 routes of spread which have been documented in literature, and that is the TB spreads enters the middle ear through a existing perforation via the session tube, through hematologic spread from other. Tuberculosis otitis media may present in different pathological phases as well. It's documented as having an acute phase and a chronic phase. The acute phase has congestion followed by a thickening of the tympanic membrane and the appearance of tubercules or perforations. The otoscopic landmarks also then become obliterated. The chronic phase shows slow and painless, with perforations and pale pink granulation tissue. The diagnosis. So there's a need for a high index of suspicion for patients in endemic areas with a porphyria not responsive to conventional therapy, as stated before. Initial symptoms are very non-specific and very similar to chronic otitis media. However, patients may have constitutional symptoms and signs suggestive of pulmonary TB as well, which would include fever, night sweats, cough, and loss of weight. They require thorough clinical examination as well as a chest X-ray to review for pulmonary TB. Patients may also not present with pulmonary tuberculosis and still have tuberculosis of the ear. The clinical presentation, the classic description of TB otitis media is a painless porphyria and multiple perforations, which may correlate at some point to form a total loss of the tympanic membrane, pale granulation tissue, early severe hearing loss, and bone necrosis or bone which is denuded on mucosa. The diagram on the side of the slide demonstrates all the different signs and all the classic features of tuberculosis which have been stated in past texts. However, generally, what is found on otoscopy is a tympanic membrane perforation with pale or denuded middle ear mucosa. Multiple tympanic membrane perforations may be present, but are rarely currently reported in the literature these days. Although in other institutes we have seen tuberculosis with multiple perforations. The bone of the middle ear cleft may be denuded of mucosa in up to 30% of the patients. Hearing loss is usually conducted due to tympanic membrane perforation, but it is not uncommon to have a mixed hearing loss disproportionate to the disease at hand. The signs and symptoms of possible TB which have been postulated are 3 things: a hearing loss, which is disproportionate to otoscopic findings, the absence of atalgia, and early presence of complications such as facial paralysis or paresis. In terms of bacteriology, positive cultures for acid-fast bacilli, tuberculosis confirms the presence of tuberculosis otitis media, but ear discharge provides a very poor yield of positive cultures. Due to the low bacterial count which is found in the ear discharge, as well as positive salts for culture sensitivity. So positive salts for culture sensitivity is diagnostic in less than 20% because of this reason. A PCR has been used in pus and tissue specimens to confirm the diagnosis, which is proven to be valuable in certain texts. In a recent study done at Red Cross Hospital, TB PCR tests were noted to have the fastest turnaround time and enabled early treatment, which would decrease the amount of complications occurring. In terms of the histopathology, an examination of the biopsy specimens is the most definitive way of confirming the diagnosis of tuberculosis otitis media and tuberculosis of the temporal bone. It requires a biopsy of granulation tissue, middle ear polyps, or tissue removed at mastodectomy. The microscopic findings strongly suggest that TB are granulomata with caseous necrosis, epithelioid cells, as well as Langerhans giant cells. False negative rates of histopathological diagnosis is suggested to be around 10%. So it's still the best way of diagnosing. In terms of imaging, CT scans of the temporal bone is the radiological investigation of choice. They generally demonstrate the presence of soft tissue in the middle ear cleft, relatively well-preserved mastoid SL system. Typically, minimal sclerosis of the mastoid and mucosal thickening of the bony external auditory canal, as well as soft tissue extension within the external auditory canal without erosion of the scutum, which is very relevant because this is the erosion of the scutum, erosion of the ossicles is usually seen early in cholesteatoma, which is one of the biggest differentials. In advanced disease, there is diffuse destruction of the temporal bone, diffuse destruction of the temporal bone with not just a destruction of the scutum seen in the temple. The CT is important for the degree of involvement of the temporal bone in most cases. So it is the investigation of choice in terms of imaging to begin with. So there is criteria which has been laid out from Rowe et al. In 2007, high resolution CT criteria for TB mastoiditis compared to other forms of mastoiditis has been reported. So the key findings include a soft tissue filling of the entire middle ear cavity with extensive bone erosion and involvement of diagnostic challenges. So the diagnosis is difficult to confirm early in the disease because due to the absence of the clinical findings and the very high false negative rate of fractional cultures. The widespread use of neomycin and drops can also mask the clinical features of tuberculosis. These drugs have tuberculosis effect. Early treatments can prevent complications such as irreversible hearing loss as well as a facial nerve palsy. Differential diagnosis includes other chronic conditions affecting the temporal bone, such as Wegener's granulomatosis, histocytosis, chronic otitis media, cholesteatoma, as stated earlier, histoplasmosis, blastomyosis, syphilis, and lymphoma. From the study that was done at Red Cross Hospital, which was done 2 years ago, they came up with a diagnostic algorithm in terms of a workup for diagnosis and treatment of tuberculosis. Start with mastoiditis with a positive history of a TB contact or in an endemic area constitution. And then if it's still not diagnosed, we go on to an early bone. We go on to CT scan, which would show early bone destruction of the temporal bone with a secular involvement. Then intraoperative examination will be done, which will show typical pale granulation tissue, and which will be confirmed with pathological diagnosis. In terms of complications, in children, complications are commoner and tend to be more severe. Facial nerve palsy and tuberculosis media is reported in 16% of adults, but 35% of children. Granulation tissue invading the fallopian canal, as well as compression of facial nerve, results in a facial nerve palsy in 10 to 20% of the patients. Spreading of the infection into the cochlea can result in profound hearing loss. Other complications include a post-oral fistula, temporomandibular joint involvement, intracranial complications such as meningitis, tuberculomata, otitis hydrocephalus, and multiple cranial palsies. In terms of management, there are two components to the treatment including anti-tuberculosis therapy and surgery. Once the tuberculosis diagnosis is confirmed, medical management with anti-tuberculosis therapy is the mainstay of treatment. Anti-tuberculosis therapy using the current standard medication for a minimum of 3 months is recommended. Longer periods of tuberculosis treatment may be required in cases of disseminated tuberculosis as well as tuberculosis meningitis. Surgery may be required for a number of reasons. One is to obtain tissue for histology, which is the most common reason. Drainage of subperiosteal abscess and removal of bone sequestration. For the purpose of facial nerve decompression in medical management, if medical management fails to demonstrate clinical improvement of facial nerve function. However, the role of surgery for facial nerve palsy in tuberculosis is contentious, as similar results have been reported with medical management alone. With medical management alone, the resolution of autourea can be seen in 2 to 3 weeks of treatment, and the disappearance of granulation tissue can be observed in 1 to 5 months. Some literature suggests that the combined modality treatment with surgery and anti-tuberculosis therapy will be more effective and result in quicker healing and better outcome, but this has not been proven in systematic reviews of other studies. In the case of bilateral tuberculosis type media resulting in bilateral profound hearing loss, cochlear implantation is an option for hearing restoration. However, labyrinthine ossificans that follow tuberculosis type media can make this a difficult procedure. So, in conclusion, tuberculosis of the temporal bone is a rare condition, and however, most cases have been reported in Africa and Asia, where tuberculosis is endemic, and which makes it more relevant for doctors working in South Africa. Symptoms and signs are similar to chronic active otitis media with often no specific clinical features. Confirmation of the diagnosis is difficult as bacteriology is very insensitive. Histopathology is often required to confirm the diagnosis. PCR has faster results, but has not been proven to be the diagnosis in most circumstances. Complications can occur early, including profound hearing loss, facial palsy, and facial palsy and the mainstay of management in the medical is anti-tuberculosis therapy for 6 months longer, and a mastectomy with or without facial nerve decompression is reserved for patients who do not respond to medical. Of note, clinicians must have a high index of suspicion for patients with persistent autourea, resistant to standard medical therapy, or when complications occur disproportionately early in the disease process. And these are my references. Thank you very much.
Yeah, that's really good. Is Ashley Harris on the call? She's in the car. With Charlie, I'll check.
Let's see. No.
No. Have you ever seen TV? No? You seen TV? No. You people did, but you tried. Yeah. Yeah, I mean, you've got a high index of suspicion, as you said. And but as you point out, it is really medical disease. But if you remember years ago, we go in on these and you start building all the soft bone, really soft. But you're building out bone that will recover with medical care.
Well, most of the literature says in terms of surgery that you don't really need to do a cortical mastectomy to get specimens. It's never actually a therapeutic procedure. It's mostly just a diagnostic procedure in this instance.
That's my understanding too. So you want to look at the surgery to getting to making a diagnosis. I mean, you can get a secondary infection in the setting of TB as well, which is sometimes you might have to do acute vasculitis situation. But if you come down on the soft bone, it's a bit like butter. You just keep drilling on this soft bone, and you just get to drill away the skull base. And so you want to be concerned. So I think that's the main issue really. And and want to make a diagnosis, they say histology was PCR was culture. The culture will take some time to get back.
Yeah. So in a study done at Red Cross Hospital, we actually had a time period for how long it took to get results. And they said that the culture took the longest, but the fastest culture they got was 7 days.
Yes. Is there anyone who'd like to, yours here, would you like to comment on the histology of TB of the mastoid?
Sure.
Professor Hiller, yours, can you hear us?
Prof. Philip?
You can unmute himself.
Any other comments about it?
No,
It is a high suspicion and they want to make a diagnosis.
Yeah.
And patients with HIV.
Hello, good morning.
Yours,
Good morning.
hi.
Good morning. Hi, on. Good morning, everybody. With the TB, yes, look, it is clear that granulomatous inflammation with case necrosis is what we always, would like to see in TB. But sometimes you can get, and obviously the presence of Ziehl-Neelsen positive organisms, but that's not always what we can achieve. So sometimes there is no evidence of organisms in the tissue, and also gene expert can on the tissue itself can actually be negative. But that is what we see sometimes. But obviously, once we see granulomatous inflammation, in any case, obviously the patient needs to be worked up for TB sputum with gene expert. That's how we would go.
Okay, a problem is that the lungs could be negative, of course. It could be extra palmy TB. So
Yes.
Our focus tends to be on the tissue that we harvest.
Yeah, extrapulmonary TB sometimes can be quite, it can be very suggestive. And usually, look, it's always the first three options that you have TB or 2 TB, 3 TB, and then something else, because in this country, that's granulomatous inflammation with necrosis is associated with. But, obviously, you'll have always the possibility of sarcoidosis. But that's histologically slightly different. But you can get florid TB without presence of microbacteria detectable in the tissue, which can be quite a problem. But you'll have to assume it is TB and do a general workup in any case.
Yeah. Zubair, do you have any comments from your side? Do you see the power of practice at all?
Yes, I've seen recently a case where we had an older gentleman in the parotid, florid TB type granulomatous inflammation with involvement of 2 lymph nodes in the neck. And we couldn't find any single bacteria nor on sputum, nor on tissue gene expert. But you have to treat him for TB. The question is that he was not responding very well on the TB medication, and the question is, what do you do if you can't find the TB organism, and yet everything indicates that it is TB? So I think can be quite a challenge for the physician to determine whether you should lower the dose or you keep on with the dose. In the case you cannot demonstrate the presence of active TB.
Yeah, thanks, Jos.
Bacteria.
Zubair, do you have any comments to make from your side? Yeah, you guys will have time. Zubair, can you hear us? Okay, well, with a very nice.
Sorry.
Yeah, hi Zubair. Hi, do you have any comments to make?
No, this nothing. It's a good presentation. I think I like the protocol that has been proposed by Shazia, and but otherwise, it's important to have a high index of suspicion. sometimes you do see some granulomatous diseases that are not TB. It's very rare, but you now and then, if some of the guys in Pretoria, I've seen one patient who really struggled with inflammatory disease of the temporal bone and not getting specific diagnosis. And then you need to think about non-TB granulomatous disease. But that's just but it's quite rare. Quite rare.
Thank you very much. Any other comments from here? Okay, thank you very much. Thanks for joining us. It was really, very nice, nice overview of something that we're seeing actually quite commonly here at the moment.
More recently, we know patients.
Thank you.
Thank you very much for your time, and we'll see you on Friday. Right. Bye.
Right. Have you met everybody?